Guys, look at this question here. This one. A farmer, okay, has been found unconscious in the field. There's a bottle of poison behind him. They didn't say what is that what that poison is. There is a bottle of poison beside him. Okay. His pupils are pinpoint. Breath smells of kerosene-like odor. Pulse rate is 54 per minute. It is bradycardia. So, pinpoint pupils, remember. Poison is there next to him. He's unconscious. What is the most likely diagnosis? How to manage him? For 5 marks, you have to write this. Okay. So, let's start with this. So, a farmer is unconscious in the field with a bottle of poison besides him. So this poison can be an organophosphorus poison because it is very commonly used for pesticide, insecticide. So very common. And pupils are pinpoint, showing that there is meiosis. Meiosis means what? Relaxed state, right? So it is a parasympathetic activity. Okay, so then pulse rate is 54 per minute. This you cannot trust because there can be bradycardia and then there can be some reflex tachycardia. So this will not clearly give you an idea. But here what you will focus on is pinpoint pupil. Okay, very important. And there is a poison next to him. So most likely diagnosis is an organophosphate poisoning. So look at this, guys. Here we are talking about, see, most commonly what is there in India is what you have to write. The most commonly what happens is OP poisoning, that is organophosphate poisoning. Okay. So these are, organophosphates are irreversible anticholine esterases. Okay. So what will happen? Your choline, it is a cholinergic drug. So it is going to increase the choline, acetylcholine you can say. So it is going to have what? Parasympathomimetic activity, cholinomimetic, parasympathomimetic activity. That is what will happen. The person will, he'll secrete, sweat, lacrimation, all salivation. He will secrete digestive enzymes. He will urinate. He will defecate. Then what will happen? You can see pinpoint pupil here. All this is because of what? This poison here that this person might have consumed malathion or any other organophosphorus. Malathion, diazinon. Okay, so it can be these mostly. Okay, malathion, diazinon. We will talk about OP poisoning, but it can be a carbamate poisoning also. Okay, but here we are talking about most possible diagnosis is what we are telling. They are asking most likely diagnosis OP poisoning. Okay. So look at the clinical features. You have muscarinic effects, nicotinic effects. So muscarinic means nausea, vomiting, abdominal pain, fecal incontinence, increased bronchial secretion, sweating, salivation, lacrimation, meiosis, increased urination, incontinence, bradycardia, or there can be reflex tachycardia, hypotension, okay, etc. Nicotinic manifestations, NMJ, neuromuscular junction. So there'll be twitching, fasciculation, weakness, respiratory paralysis, which is affecting the muscles, okay. So what is accumulating here, guys? Do you understand what is accumulating here? It is the acetylcholine. So cholinergic drug, right? So we talked about the muscarinic and nicotinic. So now let us go to the CNS manifestations: irritability, tremors, convulsions, ataxia, disorientation, confusion, coma. Okay. Then there can be delayed polyneuropathy. Okay. That is, they're saying organophosphate induced delayed polyneuropathy can happen. So cramping, muscle pain in the lower limbs, distal numbness, paresthesia, followed by progressive weakness, depression of deep tendon reflexes in lower limbs and severe cases in upper limbs. Okay, depression in the deep tendon reflexes. Did you get this, guys? They have divided it into 4 parts. Muscarinic, that has nothing to do with muscles. Nicotinic, where they are saying the muscles are affected. Then you have the CNS symptoms, and then they are talking about organophosphorus induced delayed neuropathy or something like that. What is that? Organophosphate induced delayed polyneuropathy. Okay, multiple nerves, polyneuropathy. Okay, mostly affecting the lower limbs. So depression of deep tendon reflexes in lower limbs, mostly they are saying will get affected. So what is getting built up here? Acetylcholine. So even death can occur, they are saying. Okay. So most likely diagnosis we have told you. Now we will see the management, right? So most likely diagnosis is done. Now let us look at how to manage him. First, you will remove the patient from the site of exposure, remove the clothes so that you will, any more absorption you can stop, wash the skin with soap and water, Then you will, if he has ingested it, then gastric lavage to get everything out of the stomach, right? If it is within the first hour of ingestion, they are saying, then you can give activated charcoal to make sure that it is a universal antidote, so it can absorb everything. And then you will manage airway, breathing, circulation, etc. Airway, you'll give oxygen. Then you can ventilate the patient if required. Benzodiazepines for convulsions if he has convulsions. Okay. When it comes to specific treatment targeted, then it is atropine. Atropine is a anticholinergic drug, so it will what it will do is it will increase the heart rate. How much you should give, this is very important. 2 milligram IV. 2 you can remember, means 2 is always a milligram understood. 2 IV, right? Every 10 minutes, every 10 minutes you have to go on giving 2 milli. It is the main antidote. The main antidote is atropine. Remember, atropine, atropine, atropine. So look here, this is the drug here that they want to give, that is atropine. This is a natural alkaloid. It's an anticholinergic drug, muscarinic antagonist, atropinic drugs, or parasympatholytics. So it will break that parasympathetic stuff, so that person will not secrete the saliva, right? The salivation will not be there. So that time dry mouth. So that is the atropinization. That time you can stop giving atropine every 10 minutes. Okay. So that is what they are saying, which is the main antidote, guys, for OP poisoning, atropine. So to say that atropinization has occurred, there should be heart rate greater than 80 beats per minute. Pupils are no longer pinpoint pupil. There will be a dry axilla, that is, they are not sweating. Systolic blood pressure will be greater than 90 millimeter of mercury. Okay, so all these are targeted endpoints for atropine therapy. What they are saying is, if that you give atropine and in 5 minutes atropinization you are not seeing, then double the dose of atropine they are saying for the next injection. That's what they are saying here. If after 5 minutes of consistent improvement has not occurred, okay, then you double the dose of atropine every time. Okay. Continue to double each time that there is no adequate response. So this is what the textbook says, and I'm saying that what did they say? Initially start off with 2 mg IV, then for 10 minutes, right? Every 10 minutes you have to keep on checking if the atropinization has happened or not, otherwise you will double, they are saying. Okay. Once this person is atropinized, then you will set up an infusion, then continuously you will start giving. Okay. One more specific therapy is the pralidoxime, guys. 2-PAM. 2-PAM is what? Pralidoxime. Okay, this is only for OP poisoning. You cannot give it for carbamate poisoning. Basically, what pralidoxime does, if early you catch, then you can give pralidoxime. So what it does is, you have to give some 30 mg per kg IV initially over 20 minutes. Over 20 minutes they are giving, not suddenly. Okay. And then constant infusion they're talking about. So basically what it does in OP poisoning, pralidoxime will go and sit on that acetylcholine esterase, right, in one site, and in the other site that, so let me explain that. So if this is your acetylcholine esterase, in the positive site that OP will be sitting, that OP poison will be sitting, right? So now what will happen? Once you give the PAM will go and block, attach here, and OP would have attached here. These two will now form a bond, and then they will come out. The PAM and OP will come out, and this acetylcholine esterase will become free. That time it will go and destroy the acetylcholine. Okay. So that they have explained here again. This is anticholine esterase. This is the enzyme, right, to which your organophosphate has bound, because of which it is not able to degrade acetylcholine. Lot of acetylcholine will build up in the person. So now what you do, give pralidoxime. Pralidoxime, if you give, it will go and bind to one of the sites of this acetylcholine esterase, and then it will link with this organophosphate, and these two will join hands, and they leave the acetylcholine esterase enzyme free. That time this acetylcholine esterase will go and destroy acetylcholine, right? That time acetylcholine levels will come down. So it will become a parasympatholytic. Okay. So you can see here, when this enzyme is free, it is breaking acetylcholine into acetyl and choline. Okay. Now it cannot break carbamate. It cannot do any. Carbamate binds to both sides of this enzyme. So carbamates cannot be removed by pralidoxime. But pralidoxime will help in which poisoning? Organophosphate poisoning. Okay. Who will help? Pralidoxime. 2-PAM. Okay. It can help only in OP poisoning, not in carbamate poisoning. So look at the question that we were trying to address. So the farmer is unconscious. Okay. Pulse rate is 54 per minute. He has pupils are pinpoint. So what and all your airway, breathing, circulation. Okay. Then atropine, pralidoxime. You will give IV fluids if there is hypotension, by benzodiazepine for seizure or agitation if required, because you'll have to intubate also and provide ventilation because this person is unconscious. Then what else? You can measure the cholinesterase levels, okay, to assess the severity. Then that's it. Okay, you can do some lab test also, they are saying, to check the cholinesterase levels. Okay. So one test they are saying is the cholinesterase levels you can check, they are saying. Okay. So cholinesterase level is a test.